North Carolina Maternal Health and Innovation Community of Practice. Today's topic is maternal and mental health policies and advocacy beyond the fourth trimester, navigating perinatal mental health. And we're so excited to have Erin from Postpartum Support International, North Carolina, here with us. Without further ado, I'm going to turn it over to Erin.
Thanks so much, Suzanne, and thanks so much for having me today. So I'm going to first apologize that in advance my allergies because of the fall, it's fake fall. My allergies decided that they wanted to flare up today. So if you hear me sniffling, it's because of my allergies. I always like to preface that because it can get get kind of loud. And I'm doing my best. So I'm here to talk, as Suzanne mentioned, about perinatal mental health. I am a doula. I'm currently not practicing because I am in graduate school for clinical mental health counseling, but I still find myself doing the work in other ways, in other capacities. I'm also the co-chair and advocacy lead with Postpartum Support International's North Carolina chapter. So today we're going to talk about a few different things. We're going to start off defining perinatal mental health in fourth trimester. I don't feel like I need to go into really big depth with that, but just so that we all have kind of a central one kind of definition to ground us. And then we're going to build off of that, talking about the variations in perinatal mental health and looking at signs and symptoms, talking about different ways that healthcare providers and the workforce in general can support families dealing with perinatal mental health conditions. And then we're going to move into the advocacy efforts and policies that we can see both at the local level, state level as well. But first, I'm going to kind of ground us in this first piece and talk about what brought me to this space. So I had my daughter in 2018. I was in the midst of potentially changing career paths when I got pregnant, and I decided that I was going to stay in my role just because it was too much trying to go on. I also became pregnant when I was living at a distance from my then husband, her father, and we were living in different areas because of an abusive situation and trying to kind of work through that. And I say that because that really feeds into kind of then our story. At 4 months postpartum, right when I had returned back to work, I saw the signs of abuse coming back pretty rapidly and decided that I needed to leave. So my daughter and I picked up, we lived I gave birth to her in Cary. We moved to the northeastern part of the state to my hometown and lived with my parents until about 2021. And then we moved out and got a place of our own. So the first, I would say, about 20 months of her life was me navigating all of that situation of the stress and the anxiety of dealing with an abusive partner, even from a distance, who was still trying to fight for custody of my daughter and trying to navigate that. So I feel like I was living in that survival mode. Even when the divorce got finalized, the end of 2019, I still felt like I couldn't relax, but I seemed to catch a break for about a month and a half until early February. At that point, I was finally finished with my doula training. I was starting to take clients, and as babies often do, they like to come at night. And my daughter was still breastfeeding at night. So I began to night wean her. And within a few days' time, I started experiencing really rapid, intrusive thoughts that just would not stop. And it would be at nighttime, which then impacted my sleep, which meant then I was going to have less sleep, more anxiety. The intrusive thoughts continued throughout the day. They were really bothering me during the day, like I could not function at work. And so after about 2 weeks of this, I went to my primary care provider and said, look, I don't know what is going on. You told me to come in. If something ever bothered me, like, what do I do? And he quickly gave me a prescription. Okay, you need a prescription for this. The caveat is you need to stop your breastfeeding immediately. You can't breastfeed. So I walked out of that office thinking, well, I'm going to throw this script away because did you not just hear I dropped one breastfeeding session in the middle of the night and that's what happened? I can only imagine what will happen if I cut cold turkey. Not only for my mental health, I don't know if the medication will help enough. And how will that impact my daughter? Because it was tough dropping the middle of the night feed. I And this is where kind of this reoccurring theme that I'm going to talk about in this presentation comes in. Because of my work as a doula, I was really good friends with the lactation consultant. I called the lactation consultant, told her the situation, told her the medication, and was crying like, I don't know what to do. And she said, that medication is fine. You're okay. That's one of the safest ones. You can continue to breastfeed. Because I was ready to just say, forget it. I will wean this child when she is 5 or whatever time. And so that was one of those key first touch points was, had I not had that, I don't know what I would have done. I don't know what my journey would have looked like. A month after starting that medication, which did very much help, the pandemic started. So I was not unable to get access. That combined with the fact that I was paying for direct primary care. I didn't have insurance because I was considered to be a contract employee. I could not access therapy. I made too much money to be considered to qualify for Medicaid. We had already gone through this process because my daughter was also diagnosed with a speech delay, and we were going through a whole process with her. And I couldn't afford out of pocket to pay or to have insurance. So I went without for about 6 months. And thankfully, due to the pandemic, my company then shifted me around and said, "Oh, well, we want you as a W-9 employee, so we can get money for you from the pandemic funds." And then I was able to finally have insurance again, and I was able to go through counseling and figure out that, oh my gosh, I've had undiagnosed anxiety since as far back as I can remember. And that part of my story, although I was already familiar with Postpartum Support International as a doula, my own journey through postpartum anxiety, through going through the intimate partner violence with my ex-husband, has what kind of set me on this path that I wanted to then advocate and raise awareness around perinatal mental health, and eventually decided to go back to school to become a clinical mental health counselor and focus on that. So what is the 4th trimester? So we know the three trimesters within pregnancy, very well known. So the 4th trimester makes sense that it's going to be the first 3 months or the first 12 weeks after giving birth. However, one of the reason I have an asterisk next to it is that similar to when your child turns 1, the postpartum or the 4th trimester doesn't necessarily magically end. Any of the issues doesn't magically end at the end of those 12 weeks, especially from a mental health standpoint. We would hope by that point you should be past some of the other issues such as the postpartum bleeding, but other aspects of this transition and change don't magically shut off at the end of those 12 weeks. The 4th trimester is not known as well. However, especially with the work of the 4th Trimester Project and so many other amazing organizations, it is becoming more well known, and we are talking to families about it more. And so more and more families are aware that, hey, it doesn't just magically end at pregnancy. However, one of the key pieces of this is that the focus often shifts to baby. And so the birthing person is just kind of forgotten. And then their story doesn't end just because they gave birth. They're still going through a lot of things. There's hormonal changes, there's sleep, appetite changes, mental health. There's also, I don't think it can be talked about enough, how much there is a shift in identity and autonomy, especially if you are not only because you birthed this baby and now you are taking care and you are responsible for this baby, but also, I mean, for me, my journey was breastfeeding, and you suddenly do not really have ownership of your body because you're kind of on this tiny human's clock, or on a clock that a schedule to make sure that you get all the feeds in. There's a lot of transitions when it comes to interpersonal relationships, friendships, friends that may not have children. There may be some, stress there in terms of, well, you can't show up the same way in those friendships and relationships as you could pre-baby. And there's also we need to consider trauma. There could be potential trauma that occurs during pregnancy and the birth that then again impacts postpartum. It's estimated about 30% of birthing people report that they've had a traumatic birth. And that means that in that piece, there's approximately 8% of birthing people report experiencing PTSD, and that percentage increases to 18% in high-risk populations such as Black, Indigenous, and people of color, and LGBTQ+. So I don't think I have to share, I don't think I have to go into depth about this, but one of that key pieces that I always share it with my families when I do childbirth education or when I talk to anybody in general is when you have a baby, you have all these hormones that of course are helping grow and keep that pregnancy and sustain it. But then all of a sudden that is rapidly changing right after you give birth. And so those changes, those hormones are going to cause some other changes that show up in our bodies, such as physical and biological changes. It's oftentimes where we're also looking at those baby blues. So perinatal mental health. This term it's gone through maternal mental health. I know PMADS has also been one, perinatal mood and anxiety disorders. I like the perinatal mental health just because it kind of encompasses everything. It's throughout pregnancy and 1 year postpartum. That 1 year postpartum is marked by the DSM-V. However, again, it doesn't magically shut off and postpartum doesn't magically end when your child turns 1 year old. And it's comprised of many mental health concerns, including depression, anxiety, panic disorder, obsessive compulsive disorder, post-traumatic stress disorder, bipolars 1 and 2, and psychosis. And I like to put those in there too as well, because those can happen during pregnancy or postpartum. It's not just postpartum depression anymore, which is even 6 years ago when I had my daughter was something that I was on the lookout for. I wasn't looking for anxiety. We also know that statistically, it's the most common complication of childbirth, more common than gestational diabetes, perinatal hypertension, and preeclampsia combined. And I always like to note this because those 3 particular issues are things that we're always educating about. We're always checking for. You know that you have to go through your glucose tests. I can remember being talked about, learning about if you ever see spots, to call the nurse because of preeclampsia warning signs, but nobody ever talked to me about what to do if I suddenly wasn't feeling like myself in terms of like a mental standpoint. So when I learned about this statistic, it was just really kind of like eye-opening. Approximately 50% of women who are diagnosed with postpartum depression experience symptoms during pregnancy, but it wasn't caught. Another really eye-opening statistic is that less than 15% of women diagnosed will receive treatment. That means 85% of people are walking around with just no treatment. And there are multitude of reasons why, and we'll talk about that a little bit later. 20% of perinatal mental health issues occur during pregnancy through that first 2 years postpartum. And then 13% of parents are still experiencing perinatal mental health issues at 4 years postpartum. I will share a little bit later about postpartum support international support groups, but I helped co-facilitate over the last 2 years one of their groups for parents of 1 to 4 year olds. And it's really important because yes, it happens most often during those first 2 years, but if you think about 1 to 4 year olds, that's a huge span of time and so many changes and so many different things that the child is going through, and then how that can shift just from a mental health standpoint. And that's not thinking and considering any past trauma, any adverse childhood experiences, any of those things. So the signs and symptoms. And I always share about this. And I always think like some of these are really difficult to think about because some of these are just normal after, you've had a baby. There's changes in appetite, especially if you're breastfeeding. Nobody warned me about the amount of cravings I was going to have and the increased appetite I was going to have because I was trying to produce milk for my child. Difficulty sleeping, feeling unusually irritable or angry, feeling like you can't bond with your baby. I've had moms say that, I can't even picture this baby as being mine. Feeling sad or depressed, feeling anxious or panicky, upsetting or intrusive thoughts about hurting yourself or baby, feeling out of control, and then worrying that you shouldn't have become a parent. And one of the key pieces that I always share is that some of these will happen just in that normal range where you're having that difficulty sleeping. That's very common, the changes in appetite, feeling like, oh my gosh, I shouldn't have been a parent. Where's the manual for this baby? What happened? Did I miss it? And it's, as you can see, baby blues, 50 to 85% of mothers are experiencing that in the first 2 weeks after birth. However, after those 2 weeks, generally, we're not seeing that continuing. And that is when we're starting to consider, well, there's perinatal mental health. We're also looking not only about the symptoms going longer, but also how intense are these? That feeling out of control, okay, you might feel that in the beginning, but how intensely are you feeling that? The thoughts of hurting self or baby are definitely more signs of we're looking at this as something more intensive than baby blues. And then we have contributing factors. So there's really three kind of big categories: biological, psychological, and environment. So biology, there's these risk factors or things that could potentially then play in. We know that from the postpartum depression standpoint, there is a gene that is linked with that. But there are also, again, if you have these other risk factors or contributing factors, that elevates your risk. So first off the bat, if you've had mental health issues, a personal history, or even family history, that shows up as a really high contributing factor. If you struggled to get pregnant, if you're sensitive to hormonal changes, that's a definite big one. Any pregnancy complications, if there was a loss at some point in your history, if there are feeding complications after giving birth, if you're not sleeping, excuse me, or there's pain, all of those things are going to contribute. Excuse me. Then you have psychological. So trying to shift my screen around so I can see everything. So the personal history of mental health repercussions, again, as a result of those pregnancy complications, fertility challenges, or loss. That identity shift again comes up, that struggle with perfectionism or unrealistic expectations. This present day, we're dealing with many different avenues of social media that really kind of puts on that facade of like, this is what motherhood should look like. And we can really struggle to kind of measure up to what we feel we're supposed to be doing. There's a history of trauma or abuse, returning to work, or worry, fears, negative memories. And then environment is super important. If you think about from like a psychological standpoint, the Maslow's hierarchy of needs, you want to make sure, excuse me, that all of your other basic needs are met in order to make sure that mental health wise, you were able to kind of function at your optimum. If basic things such as access to healthcare, housing, having clean diapers, making sure that you can get food, if those aren't taken care of, like mental health is going to be, there's no foundation to build it upon. There's also substance use history, again, the trauma and abuse, lack of support from families. If you're thinking about North Carolina, I'm a child of a military family, so we didn't always live near family. And there are many on the eastern side of the state, and then even further west with the different reserve units, there's not a family nearby. And so families, they might be dealing with deployments. So it might just be baby and mom, or baby and dad, and that, the other parent is gone. As well as NICU stays. It's something that we talk about often in our birth trauma group, is just, it doesn't matter how much time you can spend, the smallest amount of time possible in the NICU, there still are those kind of repercussions and those lasting effects. And then we want to make sure that we also highlight the high stress parenting groups, queer and trans families, families that have experienced any sort of loss, families that have gone into a NICU. A near miss survivor is someone who would have experienced, like, almost passed away during delivery. Adoptive parents, military families, parents of color, teen parents, families with multiples, and single parents, all on their own bring their own unique set of factors that then play into mental health. So looking at our state at North Carolina, so I looked through the most recent maternal mortality review report, reviewed the data from 2018 to 2019. And in looking at the 76 pregnancy-related deaths that occurred in those 2 years, they found 3 contributing factors. First and foremost was bias and discrimination that they saw was the probable contributing factor in 69.7% of the pregnancy-related deaths. Second was mental health conditions with 46.1%. And they said that approximately 24 of the 76 total deaths, mental health conditions were the overall leading cause of death. And then third was substance use disorder, with 20 of the cases attributed to overdoses. 18 out of those 20 involved opioids, and 14 of the 20 involved fentanyl. So those 3 key pieces are playing into to mental health, perinatal mental health across the state. And then based on their findings, the Maternal Mortality Review Committee made numerous recommendations, including training to recognize co-occurring substance use and mental health disorders, screening for perinatal mental health and substance use following the ACOG and the AAP guidelines at both OB appointments and child well checks. They recommended providing education regarding perinatal mental health to help decrease the stigma and increase awareness, how to find help, resources, etc. They also recommended that we provide funding to support an integrated healthcare model with OB offices and mental health resources, which we'll talk a little bit about an example of where that's being done in the state a little bit later. And they also recommended increasing funding for workforce expansion of psychiatric prescribers, therapists, community health workers, and doulas. So these were their recommendations and all of them really do support and align with that perinatal mental health focus. In 2023, the Policy Center for Maternal Mental Health, which was formerly, if you're familiar with 2020 Mom, they were formerly were known as 2020 Mom, partnered with Plum Organics to develop a risk and resource map to illustrate where in the United States moms are at the greatest risk for suffering from perinatal mental health conditions. You can see this is just a snapshot from North Carolina. You can go on this map, and I apologize, I don't have the link very easily. I didn't put it in my notes, but I'm happy to grab it and send it later. You can see the darker the county, the more higher risk. You can also see down here the risk factor score. There's nothing selected, so they're not going to show anything, but you can click on a county and it will show you how many providers there are, the estimated annual births in that county, and then what is the provider to birth ratio. And based on this, we're looking at the standard is one perinatal mental health trained provider for every 200 birthing people. If you do not meet that, then the county for each of those kind of layers, like say you have 2,000 people, so then you're going to need to make sure that you have 10 perinatal mental health providers. If you only have one, it's going to make your coloration of your county darker. So again, you can see that the ones that are really light are going to be close to not having a shortage. And as you're probably well aware, looking at some of the counties, Wake County is one of them. Wake County being as large it is and having a lot of providers here, we aren't at a shortage. But if you're looking at the other parts of the state, there is a shortage. So that's something to take into consideration. And kind of moving forward and thinking through where we want to go from here. So what can we do? We can educate, we can validate, we can screen, we can refer, we can try to bridge care or treat, and we can advocate. Education and, let me go back. Education and validation is honestly some things that we've already talked about, and we'll talk about a little bit further, but where I want to start is screening. So this is a snapshot from Maternal Mental Health Leadership Alliance, or MMHLA's big screening project that they've been working on. I think they're in year 3 now. And this is looking at what the scheduled visits are for obstetric care, as well as pediatric well child visits, and is showing where these screening recommendations are. So ACOG recommends at least, excuse me, at least screening once and during the perinatal period, or the prenatal period, and then contacting new parents within 3 weeks postpartum and screening again at that postpartum visit. However, I'm looking at this, I don't know about the rest of y'all, I only had a 6-week postpartum visit, and many times moms are not going back for that 6-week postpartum visit, so they are not being screened at all. And I can also say that during the time that I was pregnant, I never got screened at any point during my pregnancy. So while there are recommendations and they're constantly rolling out new recommendations, not everybody is enforcing them. So it's not something, this is why some families are getting through, kind of falling through the cracks. From the pediatric side, you can see the guidelines recommend perinatal mental health screening at the well baby visits, 1, 2, 4, and 6 months. I mentioned that I had my daughter in Raleigh. I was screened at months 1, 2, and 4. I was at a local pediatric clinic. I moved back to a rural county. I was not screened at the 6-month appointment. And talking with other doula clients, some of them were declining screening because they were being charged X amount of dollars for the screening tool to be completed. So while there are recommendations and we do have the good intentions, it's not necessarily always feasible to implement them, or it's not always being implemented. And I can say too that many times there are so many other things that need to be gone through at these different visits. We need to go through, glucose testing. We need to check weights. We need to do blood work. From the pediatric visit, many times we're told that, well, that's not my patient. I need to send parents back to their doctor, and they need to screen there. And we all know that we are continuing to see from a workforce standpoint that there are many clinics that are overwhelmed. There's also a lot of barriers to getting back to the OB office, or maybe after they finish their 6-week postpartum visit, the families don't necessarily have a primary care doctor to go back to. And so again, families are getting missed. And so this is why ACOG and the American Academy of Pediatrics has said, like, we've got them there. They're going to be here for these trimester visits, this prenatal care. Let's use that captured time to screen if at all possible. Some ideas for depression screening: the Edinburgh postpartum depression screening, and then the PHQ-9 are two of the evidence-based tools and the validated tools that are recommended. And when you're looking at anxiety screening, you have the PASS and you have the GAD-7. Again, these are ones that, if you look, like the GAD-7 takes 1 to 2 minutes. The APDS and the PHQ-9 is 5 minutes. One big piece of this, though, that we always want to consider is making sure that we share with patients and families that, really the reason that we're looking at this is not to be like, haha, got you. We don't want to do that. We're doing this to make sure that if you need additional resources, we know how to get you connected to those resources. So oftentimes when I go in and talk with clinics and staff, I'd say, one of the biggest keys, it's not necessarily, a big piece is when you're screening, but also how you present the screening. Are you just throwing it at them and telling them, hurry up, finish it, fill it out, because we need to get it back? We need to turn it back in. Or are they allowed to take the time and ask questions so that they understand why they're being asked, to rate how they're feeling. There's also the mood disorder questionnaire, which I want to always highlight. Bipolar disorder is definitely one that I remember learning about as a doula, that we want to make sure that you kind of keep that in the back of your mind, especially if there's a family history. Sometimes an SSRI, if you prescribe it to someone who has bipolar, it's going to have an opposite effect. So it's something to always keep in mind. And so I always bring up this with the mood disorder questionnaire. It screens for the history of mood elevation, and it can be completed in 5 minutes. So thinking back to those, what are the different steps we can do? So we went through screening. So the next one is talking about what we can do is refer. So one amazing resource that we have is the National Maternal Mental Health Hotline. It's 24/7. You can call or text. I just realized that this number is incorrect, and I apologize. The 1-833-852-6262 or 1-833-TLC-MAMA is the new line. They changed the line number from the original one. I think the old one that's listed, the 5746, is still being routed through the end of this year. But this is a call or text. In the moment, I just need to talk to someone, support hotline. It is not needed for crisis. It is not a crisis line. We always make sure that we share that if it's a crisis situation, that families call 988. But this hotline is in place to make sure that families who just really need someone to talk to or don't know what to do or what is going on, they have a place to go, and they have someone who is perinatal mental health trained to talk with, rather than potentially going to a therapist who does not have that background, potentially talking to a family member, a doctor, or someone who does not have that perinatal mental health background. They're 24/7, 365 days a year. They will respond to you in less than 5 minutes. I can guarantee you, because I've accidentally texted them before. And they have at least 67 plus languages that they can translate into. So it's to make it as accessible as possible. The Postpartum Support International Helpline is another great tool. This helpline was in place before the hotline. The helpline, though, the difference is that you can call or text and you can get connected with the helpline, like the helpline person here, during a set number of hours. If you call outside of those hours, you're not going to get connected with someone right away. It will kind of go into the call bank and then it will get then passed on to a coordinator. So it's not a 24/7 helpline. And again, it is not a crisis line, but the helpline then takes all the information from the caller, the help seeker, and then locates the area coordinator. Okay, this person is in Durham, North Carolina, so I need to find the coordinator that covers Durham. The coordinator then takes over that communication and helps the help seeker find resources. Oftentimes they're looking for a perinatal mental health provider, which is something that we can easily do, especially now with the implementation of telehealth. Prior to COVID and the telehealth kind of expansion, we often had deserts. I'm the area coordinator for the northeastern part of the state, and I can tell you if I look for a perinatal mental health provider at this point, you have to cross the border to go to Virginia, to Hampton Roads, or you have to drive all the way into Raleigh at that point in time. And so I was often faced with very limited resources, but now we have much broader access with telehealth. The coordinator can also help find other resources. Are they looking for support groups? Are they looking for local, mom and baby groups? Like they can also do some sort of community resource connection as well. We also have the postpartum or PSI peer support groups. They're all led online. They're virtual. They're free. They're generally 90 minutes long and they range from a variety of topics. They have basic perinatal mental health ones, one for postpartum, one for pregnancy. One of our newest one is the substance use recovery support for perinatal moms and birthing people. I help facilitate one of the birth trauma groups, and it's a peer support space so that parents can come together and find that community, especially around some of these specialized populations where they normally would not be able to connect with someone else who has had a similar experience to them. And that is a huge piece in the healing process and the treatment process for perinatal mental health. And then we also have the perinatal mental health discussion tool. The provider directory is something else that can be used if you're looking for providers who are perinatal mental health trained. We also are blessed within the state of North Carolina having two additional kind of tiers of help. There's Anchor Perinatal Wellness has an intensive outpatient program or IOP that offers in-person services in Raleigh at their office, or they also have a virtual IOP program. And this is really a nice integrated model, and it's a nice step up for patients who are not necessarily who could benefit from more support than just once a week therapy sessions, but are not at such an intensive level that they need to be accepted into an inpatient program. The UNC Perinatal Psychiatric Inpatient Unit is then that inpatient level. This is one of the three, there are only three of the inpatient units across the US. It was established in 2011 at UNC-Chapel Hill. It's the first one of its kind. And they're one of the sites that offers brexanolone, which is the first FDA-approved treatment for postpartum depression. I also always want to call out the fact that if you are not sure if you're a provider and you don't know what to do, that NC Matters, their consult line is really the next place to go. We constantly, if I have providers, especially don't have any understanding about perinatal mental health, they're not sure what to do, rather than just saying, I don't know what to do with this patient, they can call in and talk to one of the psychiatrists, and they can kind of decide, they can go through the case and decide what needs to happen. So this is just some of the data that they've shared about their access and who they've been able to connect with. So now we're going to pivot, and I want to look at the advocacy at the state level. So over the last few years, we've had some advocacy, again, the perinatal mental health space. One, the Perinatal Quality Collaborative of North Carolina, or PICNIC. Focused one of their, so they have initiatives each year. One of their initiatives called the Cloudy 3.0 was embedding the Edinburgh Postnatal Depression Scale in maternity care protocols at various hospitals across the state. So that, I believe, came after their 2.0 initiative was putting in a validated screening tool for substance use in maternity care protocols. So this is another way to broaden out and make sure that we are incorporating and at least screening at a touch point, which would be during discharge. Also last year, Medicaid expansion finally took place, which then helped us to cover another, I believe it was estimated 600,000 people across North Carolina that would be able to qualify because of Medicaid expansion, which means that there is more access for these people. Senators Natalie Murdoch and DeAndrea Salvador introduced the Momnibus in 2023, and then they reintroduced this session, the Momnibus 2.5, and we'll talk a little bit more about what was involved in the 2.5 here in a minute. This year, PSI North Carolina and March of Dimes North Carolina are partnering to take part in the 2024 Mind the Gap North Carolina Policy Series, and we are creating a legislative action plan addressing perinatal mental health for the 2025 session. We are also using that space to create a statewide maternal mental health task force with stakeholders across North Carolina. And then March of Dimes also, this was the first year that I recall really seeing this as a key topic area, was in their legislative agenda for the March for Change Day back in May. They included perinatal mental health, and they went and they spoke with various legislators at the General Assembly about, this is why we need to focus and incorporate perinatal mental health into the different policies that we're looking at. I also want to talk about the engagement. So engagement at the state level, there are many different ways there are a variety of different ways that professionals can interact and get involved. There's the Perinatal Health Equity Collective, or PHEC, which is tasked with kind of monitoring and seeing how we can do work that's aligned with the state's perinatal health strategic plan. Again, as I just mentioned, the Mind the Gap North Carolina Policy Series and Task Force. There's also Postpartum Support International's hosts community events called The Climb. They were formerly called The Climb Out of the Darkness. They are primarily community events to help raise awareness for families about perinatal mental health. And many of the Climb teams will host a resource fair. So it's a way of connecting the people, the families, and the community who attend these events with local resources. I've led, now this is my second year leading Raleigh's Climb, and we always make sure that we pull in a piece or an aspect of community support and resources. There's also NC Matters has a plethora of education and training opportunities through AHEC. From a standpoint of perinatal communities, there are also a growing number of support groups and programs, such as Baby Love Plus. I know that is one of their sites is in Edgecombe County. I've been working personally with them on making sure how they can add perinatal mental health into their group education. There are Smart Start and this partnership programs, Partners for Children and Families. They often have programs, for example, the Perquimans Chowan County Smart Start puts on a series called the Baby Series, and one of I want to say a 6 to 8 week group kind of education session. And I teach one of the classes every single time they run this class. I teach the one class on perinatal mental health. There's also, if you're in the Triangle Area Parenting Support, they have a program as well. And one of their topics that they go through is talking about perinatal mental health, as well as Moms Supporting Moms, which is through Safe Child. And then there's a variety of different hospital classes that are beginning to incorporate perinatal mental health into their curriculum. There's also nurse family partnerships. There are several across the state, and through their home visiting programs, their nurses are also getting trained so that they can share about perinatal mental health and also look for those signs and symptoms that we talked about. At the regional level, we do have the perinatal care regions, and we have the perinatal care region perinatal nurse champions. So in care, I know, I want to also offer that by no means is this a comprehensive list. This is what I'm aware of, and I know that we are constantly trying to grow and add to this. In the Western region, I know that there's the Perinatal Emotional Health Network, which that is a networking group for perinatal mental health providers, and that helps to connect them again, so from a standpoint of who maybe I can't take this patient, or this client just is not the right fit for me. I don't have the specialty that they're needing, but I can look within the network and find another and give that warm handoff or referral. In the Northwestern region, there's a Wake Forest University medical students that are working on a postpartum depression project. They were supposed to launch that this summer. There's also the Novant PMHC certification. They received a Duke Endowment grant, and so they are going to be training all 70 of their lactation professionals in perinatal mental health and getting them certified so that they will also be an added layer of support for families. In the Southwestern region, so Care Region 3, I had mentioned earlier that there is an OB office, Providence, that has a unique framework. They brought in, I'm not sure how many years ago, a behavioral health or a mental health provider into their practice so that if they are being seen, they're seeing clients and patients at their clinic. If they see someone that does need mental health support, rather than having to refer them out and having to kind of wait and get on somebody's wait list, they can start the process in-house using the mental health provider that they already have on staff. So it's cutting that wait time and really kind of trying to streamline that referral process. And then there's also Atrium's program to embed mental health providers in clinics. And then in the Northeastern region, there's, as I mentioned, the Triangle Area Parenting Support and Wake Med programs for support and education. Mame Incorporated also offers peer support, group support, and clinical therapy. And then Anchor Perinatal Wellness, their IOP program is located there, but they also have created a free in-person clinic for perinatal mental health screening. In the Southeastern region, so Care Region 5, there is the Healthy Start Corps, which is focused on addressing infant mortality and improving birth weights and really trying to make sure that every family has access to a comprehensive family-centered healthcare model. They are located in Robeson County. And then in Care Region 6, the Eastern, there is the Maternal Mental Health Coalition for Albemarle region, which covers the northern half of that care region. There's also the Baby Love Plus program. And then there's also community baby showers. Now, the community baby showers are, I'm sure, happening statewide. I know this because this is something that I am involved in, a project that I'm involved in, so I added that there. So from a standpoint of policies, right now, from the policies to support perinatal families, there are recommendations, as we talked about. There is no mandatory screening laws or anything in place, policies requiring that providers follow these recommendations. So at this point, they're not required. So each practice, each provider can make up their own decision about what they're going to do. Medicaid expansion was something put in place with the hope that we were going to be able to cover and support and offer healthcare to more North Carolinians. I pulled together, based on our task force, that in different various policy meetings that I've been in, when we think about policies, there are others that are being proposed, both in the 2023 or the 2024 sessions, but that have not necessarily moved forward, but would be supportive of perinatal mental health. For example, Medicaid coverage for birth and postpartum doulas, and having that streamlined more, because from a doula perspective, it can be time intensive. There's also and that was a House Bill 421 that was introduced in the 2023 session. There's also through the Momnibus 2.5 that was introduced this year, which is the Senate Bill 803. There were 3 pieces of proposed legislation, one being mandatory implicit bias training for all maternal health care providers. Thinking back, that connects back to the MMRC recommendation, because they saw so many, 69.7% of those pregnancy-related deaths were related to bias and discrimination. There's also the Momnibus called for an establishment of a grant program to fund perinatal health education programs, and mental health would be pulled underneath there, as well as training for community health workers in post-birth warning signs. And then 2 at the bottom are ones that have come out of our own task force, the Mind the Gap task force series that March of Dimes and PSI North Carolina have been working on. One being mandatory perinatal mental health training for all maternal health care providers, as well as mandatory screening requirements for perinatal mental health and substance use disorder that align with the ACOG and the AAP recommendations, which is supported, again, by the MMRC's recommendations from their latest report. So when you think about looking ahead, what are some things that we're hearing that we want to consider of how, how can we make that lasting impact? How can we've made some forward progress. How can we continue to move forward and support families so that they are not falling through the cracks, so they are not being left behind? Streamlining the referral process has come up very often. How can we streamline that? By working collaboratively with all the offices, pediatrics, to support early detection, intervention. This goes back to kind of, I mentioned my story and my journey and how I got to this space was because I had the village. I didn't necessarily have the entire village all working collaboratively together, but I knew who to go to. For example, the medication piece was a big one for me. And I was able to thankfully go back to the lactation provider because I knew her. And that's one of those things that I always talk with families about, making sure, please make sure that you have this person within your wheelhouse or within your village and your team. You may not need them now, but they may have something that you need later. So from a professional standpoint, thinking through like, how can we streamline our processes? So if I do see that I have a patient and I am a pediatric provider, how can I make sure that it gets over to the OB, or maybe they're past the 6-week point? How do I then connect with primary care providers in my area or family medicine so I can make sure that, again, that patient is supported? Increasing our perinatal mental health certified workforce. So that could be looked at as educating and training healthcare providers about perinatal mental health, as well as what resources, supports, and programs are available, training professionals how to screen, and coordinating with potentially with nonprofits and community doulas across the states to help with providing direct services through screening, and then also providing resources. So again, thinking of how we can expand kind of our village, and pulling in more stakeholders, in a sense, more members of that village to really kind of hold the families. Again, the embedding of mental health providers into OB and or pediatric clinics to bridge care versus waiting for a referral to an outside provider. Providing perinatal mental health education, continuing to do that through programs such as NC Matters, creating them and then making them available through AHEC, and helping from a continuing education standpoint, perhaps making it mandatory, which is something, again, similar to that implicit bias training. And then identifying the gaps in Medicaid coverage and work to make it more accessible so that more providers can take Medicaid. This is a topic that comes up often is, well, I want to take Medicaid patients, but I can't get paneled with Medicaid, and that having that as a barrier. From a community standpoint, how can we make sure that we are making an impact there? We can look at raising awareness around perinatal mental health and substance use disorder, creating and sharing patient-facing bilingual community resource sheets about perinatal mental health and substance use disorder, even looking from a standpoint of communities, perinatal care regions, creating a resource sheet for families to learn about local, state, and national resources. I know from a standpoint of PSI North Carolina, this is something we're trying to work on with our regional liaison program so that we can at least have one place where you can find a good amount of resources. They may not all be local, but some of these national accessible resources like the hotline and the virtual support group. So at least it's a first kind of piece for resources for families. There's also providing, again, we talked about providing direct perinatal health education to the public. This comes from a MECHAN recommendation, which is the Maternal Child Health Equity Action Network, incorporating the PMH education into prenatal care. Similar to, again, as we talk about gestational diabetes or hypertension or preeclampsia, let's also talk about perinatal mental health. And then incorporating that perinatal mental health education into already established programs, such as childbirth classes, such as programs at the health department, the Baby Love Plus group education, nurse family partnerships. And again, some of these things are already happening in different programs across the state. And it's been what we've been looking at is how can we take what's working really well in other communities and see how we can make it work for other communities. So it's not just isolated in one community, because it's not just that one community that has perinatal mental health. And then increasing awareness of screening. I showed before the the PSI mental health discussion tools. It's not a diagnostic screener, but it does give some language around, I've been feeling this way, I've been feeling this way. So wanting to share that. And then another aspect is partnering with Anchor Perinatal Wellness to host pop-up screening clinics. My last piece is around advocacy. Follow key advocacy agencies in North Carolina. So I want to mention we have March of Dimes, North Carolina. Again, the Foundation for Health Leadership and Innovation, as well as the Maternal Child Health Equity Action Network. There's also Mom Rising, NC Child, and PSI North Carolina. We are all doing some form of advocacy work, and all of us are focused, if not directly on perinatal mental health, some aspect of it that's going to then impact mental health. You can track legislation and reach out to then your local representatives and contact them about proposed legislation. And that's one way to get involved. As an organization, you can also, depending on what your organization's kind of rules are around lobbying, or at least offering support, you can contact your legislators to provide support on what they're working on. And I'll just end on this. So we all know that it takes a village to raise a child. It's also going to take a village to support the families, which is where all of us come in to play. That's all. Thank you.
Thank you so much, Erin. That was so much amazing information. And we've had requests to be able to share your slides, and we have recorded this, everyone, so you can listen to it again. We have some questions in the chat. I'm not quite sure that we're going to have time to get to them. I appreciate some folks that were able to answer some of those questions in the chat, and we can capture those for you. And also the Perinatal Health Committee, which is part of the Child Fatality Task Force, is also wanting to dive into this issue a little bit as well. So I think it's really great that we can kind of align all of this synergy in a forward direction, which I think is great. So Erin, I just want to say we are so lucky to have you in our state, and I so appreciate the energy that you bring, and I just think it's really an exciting time for us here in North Carolina, for sure. And I hope you see all of the accolades and thank yous in the chat. Also wanted to direct everyone's attention to the links about the attendee information and the evaluation and contact evaluation. And with the last few minutes, I'm going to turn it over to Suzanne for some final announcements. Thank you again, Erin.
Thank you so much, Erin. I so appreciate that. That was great. And I know that there were a lot of questions. Perhaps we can do a part 2, or we can do some sort of Q&A in some of the follow-up, because I know I got some direct questions as well. So thank you so much, Erin. Again, here's the evaluation for today. That's in the chat. You can find it in the chat. And a couple of reminders about the 4th trimester work. We have a postpartum toolkit. I think some of this stuff was mentioned in the presentation, but they're in the resource center, so newmomhealth.com/resources. There's a support plan where it's fillable. A birthing parent can come while they're pregnant, ideally, or when they're in the postpartum, to fill out how they want to be best supported. And it covers things like visitors and communication and who's going to walk the dog and what makes me feel like me, things like that. There's a medical and healthcare plan that's meant for a doula, a community health worker, an OBGYN, a midwife, to work directly with the birthing parent to fill out things like, you had a vaginal delivery, you had a C-section, this is the recovery time, these are the medications you're taking. And it has kind of the filled-in specific plan for the birthing parent. There's a visit checklist that's meant for that first postpartum visit and that conversation piece of what's important for mom to talk about, guidelines for health professionals. Probably the most used resources are the new parent health one-pagers and the new baby health one-pager, one-page printout. It covers really easy to understand who to call if there's any medical emergencies, the urgent warning signs, who to call, what to do. So that's a really great one to have printed out and put on a fridge. We also have it in a flyer version and a postcard version that's much prettier, and something that you could give to, I would give it to a mom in a little gift of, put this on your fridge. Or we have a magnet version, the birth control after baby and taking care of you. So just a reminder that those resources are there. We hope that you use them along with sharing the website and all of the different tools. We had this partnership with Nurse Nikki on the video reels, and this week we launched What to Expect with Your Postpartum Body. This is a really great one. We've gotten a lot of comments on Instagram and Facebook about, thank you for the real postpartum body and talking about kind of what to expect after you've had a baby. You can view the full playlist on this What to Expect series on our YouTube, it's on our Instagram, and it's also in that resource center. And then some products and services that our team is able to offer. Again, we're always trying to push the innovation on our website and social media and ways that we can authentically connect with both healthcare providers and also moms and birthing people and their communities around them. So please use newmomhealth.com. Those tools that are really meant for education and trainings for, again, both care workers, but also for moms and for people around them to support their education and their knowledge of postpartum topics.
Thanks, Suzanne. Just noting we're at 1. So.
Okay, I got two more things that we partnered with clinical teams and also our community partnership.
Awesome.
Thank you again, Erin and everyone for this great session. I so appreciate it.
And Suzanne, could you just pin yourself for a quick second? I wanted and stop recording. Thanks everyone for participating with us today.